about 11% are said to be suffering from multidimensional poverty. And when we say more than 50% of the population is struggling with this persistent problem, then we see that there is certainly a challenge. Data also reveals that there are deep connects between anemia and age of women, anemia and social factors. So there are social determinants of health, anemia and economic factors, anemia in where you are born, urban or rural. So there are several factors, and especially iron deficiency anemia is something that we all as concerned citizens of the country should be concerned about, because this affects the future populations, the productivity, the quality of life of the next generation. And if India has to emerge as is being propounded and said, to emerge as a developed nation in 2047, we don't have much time. Actually, we have lost a lot of time struggling at the low end of the ladder where elimination of anemia is concerned. So this is a very pertinent topic on which we all should be concerned, whether we are working directly on health or not, because quality of life is a right to life. And so I welcome on behalf of Grameen all the stalwarts, all the experts who have actually taken time to be part of this dialogue. Welcome.
Thank you, ma'am, for sharing your valuable remarks. Now let's begin our session 1, socio-cultural factors associated with anemia. I extend my warm welcome to our esteemed moderator and panelists. This session will be moderated by Dr. Soumitra Datta, consultant from Grameen Foundation India, who has 34 years of experience in the field of public health and community development. Our eminent speakers for this session are Dr. Rajorshi Datta, who has years of experience in the field of family medicine and diabetes and works as an independent consultant as a physician as well as diabetologist. Our next speaker is Dr. Saurabh Tiwari, sector lead from HCL Foundation. He is a seasoned development professional with over a decade of experience in development sector, along with hands-on knowledge of operating and managing holistic development programs and the Center of Excellence in leading CSR program. Our next speaker is Dr. Smriti Pava, Regional Director of Arogya World. She has more than 2 decades of work experience in public health and nutrition. In her professional career, she has engaged with premium government sectors such as CSO, as well as academic research institutions like ICMR, MOHFW, and FSSAI, etc. Without taking any further time, I would now request our respected moderator to lead us through this exploration. Thank you.
Thank you, Parmit. I suppose everyone can hear me, right? Can you hear me?
Yes, we can.
Yes, great. Well, good afternoon, everyone. Not only the speakers for this theme, but also everyone around for the other themes also. And as it's been rightly pointed here, tackling anemia. Yes, tackling anemia indeed is a challenge. And in spite of, having different kinds of programs, both government and non-government, since 1970, they were dealing with IV supplementation, deworming, and whatnot. Yes, we know through NFHAs or even other studies that things have not significantly changed in spite of the proportional use of the resources. So, of course, we do have different direct causes. We do have physical, mental, other causes, which the other panelists will be discussing. But one thing is very certain, since we are unable to control this for decades, socio-cultural aspect is something which is not very easy to change. And I think this is one of the reasons why we are still grappling in order to tackle this very common but impactful illness. So with this background, what we understand that there is a correlation, health issues as well as the socio-cultural determinants. I'm going to propose 2 questions to each of the 3 speakers here to have their opinion. And once that's being done, then there could be some question answers. So if there is a correlation between anemia associated with the socio-cultural factors, then my first question is, what are the specific factors why we still cannot reduce anemia in India? Specific factors. Second is, what can we do seriously to control, to commit ourselves to addressing this issue? So, what are the way forward? Especially as Ms. Bharati said that we don't have much time in order to tackle this. So, let me repeat again. What are the specific factors, social cultural factors, why we cannot reduce anemia? And the second is what we can do seriously in order to address this or in order to tackle anemia. So I first request Dr. Rajesh Datta to give his opinion. Thank you.
Am I audible? Good afternoon.
Yes.
A warm welcome to all the speakers present today. So first and foremost, I would like to state the fact that we all know that anemia is a major health crisis which is gripping our nation, and it is impacting every second woman, adolescent girl, and young children. Yet it largely remains unnoticed and unaddressed. Well, the most important health issue is anemia, which we are dealing today, and it has a physical and mental health impact, loss of productivity, which is seen among adults, fallout on education for the children. Anemia is often the result of a combination of health outcomes and social determinants. And I would be focusing on the socio-cultural aspects and the factors due to which we find it challenging to control anemia. Gender inequity within poor and less educated families plays a very important role. It is also found in well-to-do families as well, due to a lot of factors like strong cultural and traditional influence in many communities. In India, as we know, 53.1% of all women in the age group of 15 to 49 years are anemic, as compared to 22.7% of men. One of the major reasons are during menstruation in women, there is loss of blood, and we need more of nutrition at that point of time. A lot of household level insecurity is also present. Cultural practice of eating last is also one of the practices which are still prevalent in a lot of communities. Other factors could be breastfeeding. Exclusive breastfeeding practices like complementary feeding are not addressed properly in many communities, apart from the school and other places. We are not trained or given properly. Inadequate nutrition, regular menstruation, early marriage with early pregnancy, school dropouts are one of the are the main reasons of socio-cultural factors for not addressing anemia. Women also do not have access to medical counseling because of a lot of cultural norms that curb the rights of female to go to the doctors, especially male doctors, unless accompanied by a male member of the family. Women also does not has a weak bargaining position in the family. They have very little to voice, and does not play a role in decision making as compared to male counterparts. There are some changes in gender disparity which are there. Media consumption through television, advertisements, and other sources shape girls' perspective and influence them to look like models and actors. These influences prompt them to follow a certain particular strict diet, cutting back on nutritional food, therefore lacking essential nutrients in their diet, resulting in this condition. And coming to the question 2, which is put up by Dr. Datta, seriously must implement the components of Anemia Mukt Bharat on IFA supplementation with close follow-up, correct dosage, regular screening. NGOs need to intensely conduct health education on anemia with behavioral change communication mechanisms, consistent counseling hand in hand with frontline workers, coordination with ICDS, midday meals, and public distribution systems like ration shops. They must coordinate with each other. Intra-household food security with the vulnerable members through education of men in platforms like farmers groups, men groups, youth groups, and self-help groups play a very important role. Linking national health mission a national rural livelihood mission through self-help group, federation, or nutritional strategies linking with livelihood, including kitchen gardens or nutri gardens, should be encouraged. We must motivate the self-help group members to address gender disparity. We must educate adolescents on sexual and reproductive health and rights with occasional engagement of parents to address early marriage and school dropouts. So if these things are taken care of, then maybe in the next uh, NFHS 5 or NFHS 6, maybe these things can be addressed, and maybe we'll have a better percentage in reduction of anemia in our society and community. Thank you so much.
Thank you, Dr. Rajeshi, for your valuable inputs. One interesting part was, the use of the media. So we also have modern problems, cultural problems, not only the traditional one. And another thing, let me just add before I go to the next speaker, is that, well, there has been some sort of discussions in terms of whether to accept the data of NFHS 5 because of the trend reversals for whatever the reason. So the government is probably going for a special kind of screening for anemia. It's called diet and biomarker survey. So that's something. So whether it is NFHS 6 or 7, it's not the point here, but then we really have to, tackle it some. And I really appreciate some of the suggestions that, I'm sorry, my video got slightly, yes, sorry for that. So now over to Mr. Saurabh Singh with the same questions, that why we are not reducing anemia and what we can do to make it successful. And I believe there is a hand raised by Dr. Krishna Sanigrahi. Yes.
It's Saurabh Tiwari, not Saurabh Singh.
Yes.
Oh, sorry.
Saurabh
It's
Tiwari
I can see Saurabh Singh. Yes. I'm sorry. I'm sorry.
I hope my voice is audible, since there is some issue with the camera being in the rural part. So it might be some issues with the camera. So Dr. Rajorishi has talked about in depth about the issues, the factors of the social and cultural factors, those leading to the anemia part. And if you look at the NFHS 5 and NFHS 4, whether it's NFHS 3, so in my view, we are again reaching to the NFHS 3 status somewhere. And of course, there are some questions like what are the issues which are leading to this status. So मुझे अभी भी लगता है कि जो इम्प्लीमेंटेशन पार्ट वी आर टॉकिंग अबाउट, डॉक्टर अजर्शी दत्ता ने जो अभी सब कुछ कहा कि इम्प्लीमेंटेशन इज देयर, पॉलिसीज आर देयर, लॉट ऑफ प्रोग्राम्स आर देयर, बट ऑफ कोर्स देयर इज सम इश्यूज विद द इम्प्लीमेंटेशन पार्ट. फॉर एग्जांपल, अभी भी जो पॉलिसीज काम कर रही हैं, दे दोज आर लाइक फोकस्ड ऑन द कॉमन अप्रोचेस. वाइल अगर आप इसके डेटा को लेके बात करते हैं, सो द अनीमिया प्रेवलेंस इन द मेल एंड द फीमेल्स आर क्वाइट डिफरेंट. आधे से अधिक आबादी फीमेल जो पॉपुलेशन है, दैट इज इन फेसिंग इश्यूज विद द अनीमिया, वाइल अगर मेंस पॉपुलेशन देखें तो वो उसकी अभी भी आधी है. तो जो पॉलिसी पार्ट कर रही है या बिहेवियरल चेंजेस प्रैक्टिसेस की बात हम यहाँ पर कर रहे हैं, तो मुझे लगता है कि आपको पॉलिसीज भी कहीं ना कहीं जेंडर स्पेसिफिक बनानी पड़ेंगी. अगर आप इंडियन कल्चर्स की बात करें तो डिस्क्रिमिनेशन तो आपके बर्थ से ही स्टार्ट हो जाता है, जहां पर जब भी फीमेल का बर्थ होता है तो कोई ऐसे सेलिब्रेशन नहीं हो रहे हैं, बट व्हेन अ बेबी बॉय डिलीवर्स, तो उस समय पे आप उसके लिए, अगर मैं रूरल टर्म्स का यूज करूं तो छठी और 12वीं इस तरीके के कुछ ना कुछ इवेंट्स बहुत ही लार्जली लेवल पे ऑर्गेनाइज कराए जाते हैं. उसके न्यूट्रिशनल हेल्थ का बहुत केयर किया जाता है. वाइल जो फीमेल बेबी डिलीवर होती है उसके लिए सिर्फ इतना हम इंश्योर करते हैं कि दैट शी गेट सर्वाइव एनी हाउ, उतना उसको न्यूट्रिशनल स्टेटस मिल सके. प्लस जब एडोलसेंट एज की हम बात कर रहे हैं, जहां पर एक मेल काउंटर पार्ट इजिली कहीं भी बाहर निकल के थोड़े थोड़े टाइम पे कुछ ना कुछ न्यूट्रिशनल इंटेक्स को ले रहा है, और फीमेल्स के ऊपर लॉट ऑफ रिस्ट्रिक्शंस है, सोशल बाउंडेशंस हैं, और वो बाहर नहीं जा सकती हैं, तो ऑफ कोर्स उसके मील्स कहीं ना कहीं रिस्ट्रिक्टेड हो चुके हैं एज कंपेयर टू द मेल पर्सन. थर्ड, अगर मैं बात करूं तो कहीं ना कहीं मैं इकोनॉमिकल स्टेटस इसमें मैं नहीं कहूंगा कि बहुत ज्यादा प्रभावी रहा है, जो मेरा अपना एक्सपीरियंस रहा है, क्योंकि हाँ, परसेंटेजेस डेफिनेटली कहीं ना कहीं उसमें कंट्रीब्यूट कर रहे हैं कि एक लोअर इकोनॉमिक फैमिलीज में काफी ज्यादा प्रेवलेंस आपको मिलेगा, बट एक हायर इकोनॉमिक फैमिलीज में भी आपको अच्छी खासी प्रेवलेंस देखने को मिल जाती है. तो इकोनॉमिक स्टेटस को मैं उतना ज्यादा उत्तरदायित्व तो नहीं दूंगा, उतना ज्यादा रिस्पॉन्सिबल फैक्टर नहीं मानता, बट यस, जो लोगों के थॉट हैं, बिहेवियरल प्रैक्टिसेस, अगर आप कॉमन टर्मिनोलॉजीज में बात करें तो आज भी पॉपुलेशन ये कहता है कि अगर आप दुबले पतले हैं या आपके अंदर अगर एनीमिया स्टेटस है तो वो ये कहेंगे कि कुछ सालों में ये ठीक हो जाएगा ऑटोमेटिकली। ये गर्ल्स में तो होता ही है। तो एक माइंडसेट डेवलप हो चुका है कि नहीं, ये एक कॉमन चीज है, ये इतना बड़ा इशू नहीं है। जबकि अगर आप WHO के टर्म्स में देखें तो दे हैव ऑलरेडी सेड कि इसको तो एक नेशनल इमरजेंसी, इंटरनेशनल इमरजेंसी डिक्लेयर करी जानी चाहिए, बट अभी भी उसको लेके किसी तरीके का कोई स्टेप नहीं है। तो थोड़ा सा माइंडसेट चेंज करने की बात है लोगों की। न्यूट्रिशनल लिटरेसी अभी भी इंडियन कॉन्टेक्स्ट में देखा जाए तो मैं कहूंगा शायद मोर देन 90% पीपल आर न्यूट्रिशनली इलिटरेट। न्यूट्रिशन प्रायोरिटी उनकी आज भी नहीं है। उनको सिर्फ इतना लगता है कि हमें सर्वाइवल के लिए फूड इंटेक करना है, ना कि अपने न्यूट्रिशनल हेल्थ को इंप्रूव करने के लिए हमें फूड इंटेक की तरफ जाना चाहिए। प्लस अनीमिया को लेके आपने जो बात कही, NFHS 5 में जो अनीमिया मुक्त भारत का कॉन्सेप्ट लाया गया, साथ साथ में देयर आर लॉट ऑफ ऑर्गेनाइजेशन, लॉट ऑफ प्रोग्राम्स आर बीइंग इम्प्लीमेंटेड बाय देम। इवन HCL फाउंडेशन इज आल्सो रनिंग सम एनीमिया प्रोग्राम्स, जहां पर हमने ये देखा कि मोर और लेस वेज आर डिफरेंट, बट ओवरऑल ऑब्जेक्टिव इज वेरी कॉमन कि हमें अनीमिया रिडक्शन लेके आना है। और अनीमिया रिडक्शन में अगर आपने किसी फैमिली या किसी फीमेल के साथ में एक अच्छा इंटरवेंशन डेवलप कर लिया तो सिर्फ उसका आप अनीमिया बल्कि मैनेज नहीं कर रहे, साथ ही साथ शायद कुछ जो माइल्ड प्रॉब्लम्स भी वो फीमेल फेस कर रही है वो भी वहां पर क्योर हो रहा है। तो जो प्रिवेंटिव और क्यूरेटिव अप्रोचेस हैं उसमें कहीं ना कहीं एक सिमिलैरिटी लाने का प्लान आपको बनाना पड़ेगा सारी ऑर्गेनाइजेशन को या गवर्नमेंट लेवल पे भी। प्लस जो भी इसके रिस्पॉन्सिबल फैक्टर हैं, आपकी आंगनवाड़ी वर्कर्स के लिए बात डॉक्टर दत्ता ने यहाँ पर कही थी कि आंगनवाड़ी और THR और मिड डे मील्स के प्रोग्राम्स रन किए जा रहे हैं, बट मिड डे मील में भी क्या कुकिंग हो रही है और वो किस बच्चे तक कितने लेवल तक पहुंच पा रहा है, कितने टाइम तक हम उसको इंश्योर कर पा रहे हैं। सिंस अगर यूपी कॉन्टेक्स्ट की हम बात करें तो अभी भी बीच में THR उनको दिया जा रहा था, दैट इज अनइवन फॉर्म। अभी वो इक्वली फॉर्म में डिस्ट्रीब्यूशन उसका नहीं हो रहा है। बाद में वो प्रोग्राम बंद कर दिया गया और अभी वापस से रिस्टार्ट किया गया। कितने लोगों तक पहुंच पा रहा है वो देखना एक बहुत बड़ा चैलेंजिंग ऑफ कोर्स एक बात होगी, बट हर एक पॉपुलेशन में या हर एक व्यक्ति को मुझे लगता है इसके बारे में सोचना पड़ेगा कि सबसे पहले वो न्यूट्रिशनली लिटरेट हो। ये एक सबसे बड़ा इंपॉर्टेंट है। न्यूट्रिशन की प्रायोरिटी होनी चाहिए, सिर्फ एक सर्वाइवल का मोड नहीं होना चाहिए। इस बारे में भी हमें थॉट रखना पड़ेगा, इस बारे में बात करना पड़ेगा। और पॉलिसी मेकर को कहीं ना कहीं मुझे लगता है फीमेल स्पेसिफिक प्रायोरिटीज दी जानी चाहिए। टेक होम राशंस अभी भी सबके लिए इक्वली डिस्ट्रीब्यूट किया जा रहा है, जबकि मुझे लगता है कि जो भी फीमेल है उनको थोड़ा सा ये टेक होम राशन का पार्ट बढ़ाया जाना चाहिए। आयरन की जो टैबलेट्स दी जा रही हैं उनकी सप्लाईज ही नहीं है, आप उनको कहां तक उनको प्रोवाइड करा पाएंगे। इवन मैं ये नहीं कहूंगा कि गवर्नमेंट साइड से इश्यूज आ रहे हैं, ये इश्यूज आ रहे हैं सप्लायर साइड से भी, लेकिन फिर भी चीजें किसी तरीके से मेंटेन करके चलाई जा रही हैं। अगर आप इंडेंटिंग देखते हैं तो अगर आपने 100 टैबलेट की डिमांड करी तो उसके अगेंस्ट में आपकी सप्लाईज ही 30 आ रही हैं, तो आप वो ग्राउंड लेवल तक कहां तक पहुंचा पाएंगे लोगों तक। तो ये भी अपने आप में एक चैलेंज है। और पिछले 3 NFHS रिपोर्ट देखने के बाद लगता है कि एक बार हमने थोड़ा सा सक्सेस हमें जरूर मिला NFHS 4 के डेटा में, बट अगेन NFHS 5 को रेफर अगर करें तो शायद वापस हम NFHS 3 पे लौट के आ चुके हैं। और मुझे लगता है पॉलिसी मेकर्स को फिर से बैठना पड़ेगा, सारे प्रोग्राम्स को क्रिटिकली रिव्यू करना पड़ेगा और शायद एक जॉइंट फॉर्म में एक कॉमन इनिशिएटिव हमें लेके आना पड़ेगा। और जैसे पॉलिसीज आप एजुकेशन पॉलिसीज लेके आ रहे हो, आप आंगनवाड़ी के लिए न्यूट्रिशन पॉलिसीज लेके आ रहे हैं, एक अनीमिया स्पेसिफिक पॉलिसी की भी हमें बात करनी पड़ेगी। अदरवाइज ये जो पूरा लाइफ साइकिल अप्रोच अनीमिया को लेके हम बात कर रहे हैं, एडोलसेंट गर्ल्स के लिए बात कर रहे हैं, ये शायद प्रोग्राम्स तक ही लिमिटेड होके रह जाएंगे। और अगेन हर रिपोर्ट में स्टेटस एज इट इज ही रहेगा, हमें कहीं कोई सक्सेस, मुझे लगता है कि फिर हमेशा ये प्रॉब्लम बनी रहेगी। तो मुझे सिर्फ इतना ही कहना था। और आई थिंक काफी इंटेलेक्चुअल पर्सनालिटीज यहाँ पर हैं, सो वेलकम टू ऑल ऑफ यू। सॉरी मैं स्टार्टिंग में वेलकम करना भूल गया था आप सभी का। तो वेलकम टू ऑल ऑफ यू एंड आई होप कि आज इस फोरम से काफी कुछ चीजें हम लोग यहाँ से लेके जाएंगे। सो थैंक यू सो मच डॉक्टर दत्ता।
Thank you, Dr. Saurabh. It was really quite insightful, and I really like your focus on nutritional literacy as well as the mindset. And I think they're very much correlated. And this is something probably we need to address once you're suggesting if you have a specific anemia policy. Thank you, Dr. Saurabh, once again. So for this panel, our next speaker is Dr. Smriti Pawar. Yes, the same 2 questions. Please carry on, ma'am.
Hello and a very good afternoon to all of you. Dr. Datta, thank you for putting the questions so simply, which are like big questions. I wish all of us had an answer. Why what is happening, and what is the magic wand? There is no one magic wand. So you know what? And congratulations to Grameen Foundation. I do believe when many people with right passion and right focus look at a problem together, कुछ ना कुछ तो हो जाता है. It can be solved. So thank you, Grameen Foundation, for putting this panel together and giving me a slot to speak. So speakers before me have, kind of already laid out kind of the problem. And then, the ground realities. Saurabh ji, you spoke really, kind of the ground realities, which are the realities. So what I am going to do is, and I was listening to both of you very carefully. Let me bring in certain shades that you brought in about changing the mindset and changing the lens. So, and what I'm going to do is I'm going to bring some lenses to the discussion for consideration from my experience of engaging with the landscape, and kind of I do have some proof of concept to back the lens up that I'm proposing. So the first lens that I want to put across is, in the first speaker, in a country where every 1 out of 2, every other person, child and women and girls are anemic, then anemia is a norm, and so has been malnutrition, right? Undernutrition. If every one, har 3 mein se ek bachcha ya har 2 mein se every other person is that way, then that's a norm. And I do believe that, when it is a norm in the community, it is not a problem really to be solved. It is us, the converted, who know it is a problem, its repercussions, and are trying to solve it. And I'm getting this lens from my experience at this Pratham and Asar, these large NGOs which work on education. And there is a survey that is done called Annual Status of Education Report, where I was involved in at some point in my career. And the focus there was, how do you make the problem seen so that it is understood. While it is understood by policymakers, it is also understood at the level. And this whole philosophy at the point of assessments, and this whole philosophy led to Asar health surveys, in which basically the philosophy was assessments should be educative. They should nudge the ground zero, that particular household, to realize that there is a problem. And I can obviously share all these links in the chat. But the point I'm trying to make here is, how do we make sure that the community, that the people who are being measured, they also understand and realize that it is a problem to be solved? And in my opinion, citizen-led assessments can play a role here, and I'm happy to share links in the chat. So that is one, making the problem really real, so that it is not just the problem solvers or the supply side, but kind of create a pull kind of a mechanism and the demand side. And once the community is aware that, hey, we need to solve it, it is a problem, it is not a norm, community is quite, I think, intelligent and jugadu in kind of, getting the problem solved. So that is one. Second, I think both the speakers before me did touch upon a lot of determinants, and many of them were sociocultural. If you look at a lot of, I was reading, and I'm seeing the panelists, a lot of you are authors and co-authors of these huge analysis papers that have come out recently on CNNS data and NFHS. And there are a lot of determinants in terms of education status, in terms of 2 more minutes, in terms, so there are, where there are these surface level determinants, but going a layer deeper, and this nutrition literacy, health literacy. So what is it under that education or the socio-economic bracket that works? So I think, again, a body of work, I'm happy to share that, going deeper, saying, okay, what it is and why it is so, in terms of ethnographic studies or qualitative or even quantitative kind of deeper level of surveys can give us some answer and insight into the solutions. And the third and the last kind of lens that I want to bring here is, since it is the socio-cultural segment we are talking about, I think health and nutrition, prioritizing health and nutrition is not a norm for us, and so building an ecosystem for health and nutrition and starting early, so that, and after I think COVID, we have this huge opportunity to put the spotlight on on health and nutrition. And I think school-based programs, again, I'll wear my regional director Arogya World cap, saying there are these programs that have reached million plus kids and are working beautifully. There are data that have shown change in impact in behavior formations in healthy lifestyle. And now at Arogya, at least we are tweaking them and testing them to see if we can do something in anemia and micronutrient deficiencies. So these are my kind of three lenses: making the problem real, understanding the whys, going a little deeper, and building a socio-cultural ecosystem where health, nutrition is prioritized by default. I think are the three kind of lenses that should be of value in solving the problem, looking at it more closely. And I'll stop here and over to you, Dr. Datta.
Thank you so much, Dr. Smriti. You actually summarized yourself with the three lenses. But what I really like is the norm, that the whole concept of anemia being norm. And I think whatever lenses that you've talked about, it's high time that we actually change the word from norm to abnorm. So just to make anemia, to make people realize it's so important it is, and we actually have kept it as a hidden, something which is still hidden and unnoticed. That three lenses are quite appreciated. So with this, we have come to the end of the speaker's opinion on this particular theme, socio-cultural association with anemia. And now I'll leave it to the audience or anyone else who would like to ask any questions, I think, before we go to the next theme. And Parmit, how much time do we have for this short question answer session?
It's 5 minutes, Dr. Sumitra.
5 minutes. Okay, the time starts now. It's 3:30. Any question?
Yeah, can I go first? I have a question.
Sure.
Yeah.
Yes.
Really informative. I think the topic is old, but it remains contemporary, and that is a moment of shame also for us all in the development sector, that for so many years we've been working and this remains a persistent problem. So I'm really excited about the point that Dr. Smriti said about making the problem real for the people for whom it matters. And it is also a revelation for me when Dr. Tiwari says that tablets are not available. I'm just putting these two things together also. And if we study that it takes 3 to 6 months, if somebody takes a tablet, 3 to 6 months to correct the anemia, that's what it is saying. But if there are socio-cultural determinants, then households throw away the tablets, right? So I'm keen to learn if there is any model where which has been any successful experiment that has happened where socio-cultural barriers were addressed to enable communities or even clutch of households to come out of poverty. How long it takes? Because usually these changes are most difficult.
Right. In fact, just to take the cue from you, if you really look at the detailed guideline, the program guideline of Anemia Mukt Bharat, it's surprising to see all those details the government has laid out this time. Maybe they are more serious after actually getting into NFHS 5, but not trying to recognize the data. So all those things, including nudging, including very close, household visits, the follow-ups, screening. In fact, screening itself was not there, except for the pregnant woman. But regular screening, and not only that, the concept of consuming IFA, and sometimes you do experience side effects. Besides the other cultural problems, there are also side effects of IFA. There is no follow-up. after 3 months, one needs to follow up and find out whether there's any change at the level of anemia or hemoglobin percent. Every details have been given in Anemia Mukti Bharat operational guideline. But yes, I still agree with all others. For a big machinery like the government, it may not be possible. The policy has been laid. It is where, people like us or the NGOs or even at the micro level, the community level, involvement of the self-help group, the whole federation, integrating with other sectors is very important. And some of the educational themes through schools and all, I think NGO needs to play at the micro level to actually look at the reasons, to actually make people understand and realize the importance of it, which they still think is something very normal.
I
Yes.
think Smriti has.
No, I wanted to respond to
Yeah,
you,
please,
Bharti
please.
ji. First of all, tell me, I'd like to compliment you. Aapka josh, the way you're sitting, I think, we are like ready to box. So we are, it really, it's very infectious, your energy. So I just wanted to respond to you, and I wanted to share a case study. So this case study is from this village called Umar Bhari in UP. We were there, and we were kind of piloting, repiloting, testing the tools, and one of the areas was obviously IFA. And there were regular questions: how many have you eaten in this week? Did you eat whatever? And then, so I want to kind of, and I'm answering this question from the lens of going a little deeper. And when we dug a little deeper, we said, okay, why? Aapne kyun nahi khaya? So then there was some casual, kind of bhul gaye. And then obviously, the moment you give iron, the stools will turn black, and then there are other kind of problems. And like Dr. Datta, you said, there is no follow-up. Nobody is listening to this poor woman jisko we have kind of given, or even girls, we have given them the tablets and we want them to eat, right? So what is happening after that? Are there any problems? We are not kind of bothered. So as a result, in the intervention models, and now when in the school program that I just mentioned in Gujarat, what we are doing is we are trying to work with the adolescent girl and make her the ambassador of her entire family, saying your brother needs this, your chota bhai behen needs this in terms of iron, and your mother or your your chachi, whatever, pregnant, lactating, they need this. So what I'm trying to say is building an ecosystem and support system. I think so that case study really, I thought I'll share with you. And again, if we can build these thoda sa layers of putting what is happening, but why is happening. And this we didn't do qualitatively. We built in the Asar health tool, it was done, and it is a quantitative this thing which has been used, I think, across Asar happens on scale. So yeah, so I just wanted to share this.
Yeah, very, very interesting. Thank you.
Thank you, Smriti. Thank you so much. Well, I think we have completed our time, 5 minutes, and I think I put it across Parmeet to proceed for theme number 2. Thank you, everyone.
Thank you, all the expert panelists and moderators. Dr. Soumitra, for sharing your valuable perspectives and insights. I would now like to welcome our esteemed moderator, Ms. Nirmala Mishra ji, to moderate the session 2, Anemia as a Barrier to Physical and Mental Health. Ms. Nirmala Mishra is the Senior Director Programs and Lead HSS Saksham from Piramal Swasthya. She has more than 20 years of rich experience with government and international development. She has also developed policy documents for WHO, MOH, FW, and health system, etc. Our eminent speakers for the sessions are Ms. Milind Sanga Gujrar, psychologist and founder of the Happy Strokes, with 10 plus years of experience in this field. She is a holistic therapist who employs multiple modalities or methods to encourage physical, emotional, and mental well-being of an individual. Our next speaker is Dr. Sudhinath, Director of Public Health and Development Projects at BCTA India. She has nearly 2 decades of experience in the clinical and public health management of tuberculosis, HIV/AIDS, urban health, adolescent health, and research programs. And along with this, public-private partnership and has worked across functions and in many leadership roles. Our next speaker is Ms. Rupali Agarwal, CSR Head of Norbremse India Private Limited. She has more than 18 years of intensive work experience in the development sector and has completed a decade in the CSR domain with leading corporates. Handing over the session to our respected moderator, Ms. Nirmala Ji, to lead the session. Thank you.
Thank you, Parmeet, for such a lovely introduction, for the moderator, and even for our great speakers. As rightly said by the previous panelist and even the Grameen Foundation CEO, that this is a very, very pertinent theme, to discuss on anemia. And the title for this panel is Anemia is a Barrier to Physical and Mental Health. So I would like to ask my first speaker, what kind of a psychiatric, morbidity. However, this is a very broad term, but just to simplify it, what kind of a physical and mental challenges we find due to the deficiency of iron among the young children and the adolescent girls?
Hi, everybody. Thank you for having me here. Anemia is something that we girls know about, but it's not something that we actually, make a lot of effort to look after, to be very honest. And everybody would know a little bit about how anemia affects our physical health to a large extent. However, it has a huge impact on mental health, and both of these things go in a lot of ways hand to hand. For example, anemia causes a lot of disturbances in sleep, mood disturbances. Lack of iron in the brain will cause cognitive deficiencies and cognitive impairment in children. Obviously, the women are more impacted by the lack of anemia because of obviously their menstrual cycles and giving birth or birth cycles. However, it has a multifaceted effect when it comes to depression, when it comes to anxiety. Anemia plays a very high role in all of these. There have been, a lot of studies when it comes to this, that when a person is not eating well and does not have enough, nutritious meals, it would lead them to develop a lot of disorders. On the other hand, if a person is stressed, perpetual stress would lead to eating less, and that would eventually lead to obviously, a lack of mental health and a lack of looking after your mental health. Having said that, a lot of people try to talk about mental health in a lot of ways, but these days specifically youngsters are impacted because of the fad diets that are everywhere. And with social media having come into the picture, the biggest thing that has happened is there is high level of competition and body image issues, and people want to look a certain way, and because of that they would follow these fad diets which do not give them enough nutrition, which also leads to a lot of mental health and poor cognitive skill issues and things like that. So it is such an important topic to be addressed, because very few people will know the impact anemia and lack of nutritious substances in our body would have on our mental health.
Thank you so much for bringing out these issues. And actually, very right. And now our younger generation, they are so conscious to their image, to their body, and they actually are following. And social media has playing a very, very, I would say, kind of a wrong image is being portrayed to our adolescent and young generation. Thank you so much. Now coming to our next speaker. Since you are from Wish Foundation, so I would like to understand what kind of an intervention in terms of physical, considering the physical and the mental health kind of an intervention you people have designed or the organization have thought of, designing so that they can address these challenges at the grassroots level, at the community level. So over to you.
So I think that's, yeah, thank you so much, Ms. Nirmala. And I think that was meant for me, I believe, because I'm the second on the panel. Okay, thank you so much.
And since
I
you are
hope you're,
also from
yeah,
development, sector, you know the issue
yeah,
better since you're into implementation. So
yeah,
would like to.
yeah. So thank you so much. Am I audible? I mean, I hope I am audible.
Yes, you are. Yes, you are, Dr. Nath.
Absolutely. So thank you so much. I would like to extend my thank to Grameen Foundation, definitely, because of their efforts, we are here, and we've all talking together about this very important topic, that is anemia. I would also like to extend thanks to the previous panelists and also the moderator, Dr. Shaumitra, and yes, Krishna, yes, and Bharti ji for the opening, discussions which we had. Thank you so much, each one of you here. And, maybe by the end of this panel or this discussion, we are again able to reiterate that, yes, anemia is important. It is there. It has been there. And we are here to take a call how we can tackle this, or maybe learn from each other, and take each other's experience into our stride. And like Dr. Saurabh was just speaking, how the how things are happening at the rural level. So before I start, yes, Bharti ji, I resonate with you. There is no time. I say there is no time. You said there is little time left, but I say there is no time, Bharti ji, because the target 2 from WHO says that we have to reduce anemia by 50% by 2025. So we do not have time. We definitely do not have time. And the WHO report says, being in the public, I being in the public health sector, we usually often go through these reports and discuss about the targets which we have as the SDG targets. And one of the target 2 says that 25% of reduction in anemia is required by 2025. And, of course, we are all here to understand how and where and when, what we can do in each one of our capacities. So before I start, as a public health personnel, I always, we always have to deal with a little bit of statistics. So let me just take you through the statistics. Yeah. I'm not sure that am I audible or not audible. Yeah. So
Yes,
while I was going through the NFHS report 5, the 6th has not been released as yet, because it is going to take place from 22nd to 23 and 24. So as per the NFHS report 2000, fifth report, it says that 25% of in men 15 to 49 years of age group, and 57% in women, that is age group 15 to 49. Then please, I would like to draw your attention, all your attention, 31.1% in adolescent girls, and 59.1% in adolescent girls, and the first one, 31, was for boys. So here itself you can see the disparity. Here itself you can, by the prevalence which has been shown here itself you can see that, yes, anemia is a silent problem. We have been, हम लोग इससे जूझ रहे हैं, अभी से नहीं, सालों से जूझ रहे हैं, और हम ये सोच रहे हैं कि how are we going to take this forward, and what is holding back for good health for women. Being in the public health sector, dealing with the tuberculosis program, and dealing with the grassroots level, the bare minimum, when we go down to the CSCs, PSCs, primary healthcare centers, when we meet a woman, when we meet the patients who are suffering from either from diabetes or HIV, and then they are combined with the problem of having a poor nutritional background, social cultural disparity for their better health. And so it is really the most important, the most common, I would say it's a silent problem which has not been spoken about much. So it's the most common blood disorder. All of us, the panelists before me has told, I have already shared what is what is anemia, so we don't have to delve into that. But yes, definitely we need to understand that we need healthy blood cells. We need iron heavy protein inside them, which is hemoglobin. I, being a clinical doctor, I need to say this to everyone present here, as well as we share it with the panelists, that yes, these are critical cells which carry oxygen throughout the body, and definitely the low amount of oxygen restricts and wreaks havoc to the whole body. ये साइलेंट है, बहुत साइलेंट रहता है, हमें नहीं पता चलता है. और सबसे बड़ी बात जो है कि people are not aware that anemia is such a major issue. It is an issue, but we don't accept it, we don't acknowledge it. We say कि अच्छा कोई बड़ी सी बीमारी होगी बढ़िया नाम की, तो वो एक problem बन जाएगी. But that's not the case. Anemia is a very major problem which we are facing. As a public health personnel, I would definitely want to say that it's really, really, really important that we deal with this important aspect. So सबसे पहले तो स्क्रीनिंग ही एक सबसे बड़ी प्रॉब्लम आती है. स्क्रीन कैसे करें, पता कैसे चलेगा? तो ज्यादातर पेशेंट्स के सिम्टम्स तो एक अनअक्नॉलेज्ड जाते हैं. आई लाइक टू यूज द वर्ड अनअक्नॉलेज्ड, क्योंकि एज वी सेड, वेदर इट इज द अर्बन or the rural part, whichever is the case, right? Most of the times women's symptoms are misunderstood or downplayed. मैं ये 3 वर्ड्स यहाँ पे यूज करना चाहती हूँ very emphatically. I being a person who upholds my things for women things, so I just want to share that yes, ये downplay की जाते हैं, misunderstood होते हैं, and जितने भी women symptoms है, okay, I'm feeling fatigued, it's taken as okay, ठीक है भाई, okay, fine, fatigue, it's nothing to do with anemia. Anemia doesn't blink when you say it's chronic fatigue. अनीमिया कहीं पे भी आपके दिमाग में, आपके जहन में नहीं आता है जब वो वुमन जब कहती है कि आई एम फटीग्ड. You don't, that bell doesn't ring, right? So it is either downplayed or understood that this is no big deal, सबको ही होता है, there is no big deal about it. And it is so it's a throwback attitude. ठीक है, it's okay, fine, हो गया, कुछ हो गया होगा. And it's often termed as hysteria by women. Every time there is a problem with women, that is what they used to say in the rural background, and more so even in the urban background. So why anemia affects, and what is what is the physical and the mental aspect of this anemia? That is what we are here to discuss about, right? So why first, in the first case, why does anemia affect the teen girls, young women and teen girl and women at large, right? So of course they are vulnerable. Why are we vulnerable? All of us know that we are menstruating. All of us understand that our eating patterns are not so nutritious. All of us understand that we put our health on the back burner. All of us understand that we do not take, not only we, none of our other people in the family take our health for a priority. We ourselves do not take our health as a priority, right? And these are the reasons when we definitely do not have better or good health. And that is why when I started off, I showed you the statistics. There is a vast 20% difference between the male adolescent and female adolescent. Around 32% divide in the young woman and young men in terms of the anemia. That is why the divide comes, and that is how we can link these two together. This is one thing. So this condition, this regular and constant, constantly when we are not neglecting our body, they are prone to conditions which give rise to impacts on their health. physical health as well as mental health. So now a lot of people just say ki, okay, I get tired very easily. That is the normal, you once said, oh, I get tired very easily. But are we mistaking it for something else? Are we not looking forward for these things? Should we not take this into our understanding of, okay, constantly a person feeling low or feeling lethargic or feeling not up to the mark or to the energy level? I heard one of our panelists saying that Dr. Bharti ji is, full of energy. We can see that, yeah. So, but yes, that's sometimes when we see people in and around our offices, in and around our institutes, in and around our working places, wherever we go for our work, the maid coming to our home. I mean, let's forget about everything else. The maid coming to our home. Are we even bothered when she says that I'm not feeling up to the mark for a lot many days? We aren't. We aren't. Let's think back and be honest to ourselves. We aren't. Yeah. So this is what. So another widespread culprit is absolutely, I would say, nutrition. It's the poor nutrition, the poor socio-cultural, the way the women are treated. They're the last ones to eat. They keep serving, and whatever is there left over, okay, I'll partake that. Yeah, they're the last ones to eat in the family. And expressing tiredness is a luxury for them. I mean, this is something which we need to understand. Women, we need to understand. Expressing tiredness, sometimes they're even not allowed to express their tiredness, because what happens is that it's sometimes so happens that the woman is understood to be okay, this happens, keeps happening with her. So they are not, it's a luxury to express your tiredness also. So consider, what happens is, physical, if I say, it's paleness, it's tiredness, then there is tightness of chest. If you understand the physical impacts of chronic anemia is tight chest, tightness in the chest. This is one. Then pounding, when you have that palpitations or pounding, that is also one important physical aspect. Then we have some tight muscles. Okay, something is, I'm not very comfortable, that kind of a feeling. Then it's tired all the time. And then of course the panic attacks, the anxiety, and then we have constantly the bleeding pattern. Sometimes it so happens also that they have some git problems, because they're not eating okay, while I was in a field sometimes back, and we had gone to interiors of this Chhattisgarh, and I happened to meet people, ladies, who got up very early in the morning but did not eat anything, because they did not have time, because they had to go to the field. So they never ate. There are long hours of not eating, leading to A, poor nutrition, B, to constipation, C, because they do not have lack of amenities to go to. I mean, the washrooms, of course, are not available in the rural area, but even in the urban area, they're not drinking much of water. So constipation, and then, leading to, what happens is ulcers forming in the stomach ulcers, then constipation, then, you have piles, which is not so easy to explain or not so easy to share, that I am suffering from piles. There is a constant leakage of blood. There is a constant loss of blood from your body. How do you make it up? Uterine fibroids. We have long, more than 7 days of bleeding, and, extended period of DUB, that is dysfunctional uterine bleeding. That also leads to a lot of problems which we face. So, I mean, yes, anemia is still there, but let's not get anemia go unchecked. Whenever we come across, what happens is, I have a solution for this. I mean, I thought that I can implement that, and I have been implementing it within the age group of, between the age group of 9 to 11, with the early menarche now. जब पीरियड स्टार्ट होते हैं उसको मिनारकी बोलते हैं, तो मिनारकी जब ज्यादा हो रही है, जल्दी हो रही है, तो 9 से 10 की लड़कियों को अगर हम ब्लड टेस्ट पहले करवा लें, we may be able to get some understanding of whether we need to supplement this child or not. A. B is every 10 years. up to the age of, we are all will be in a reproductive age after the age of 24 or 25 or 26, whatever is the case. But every 10 years, after 9 years of age, if we get our blood checked for anemia, I think we are going to be in a better position to understand what kind of supplements, what kind of help, what kind of nutritional support the girl or the woman needs. So iron, yes, of course, is a vital, important. And secondly, nutritional to hai hi important. And like just the speaker before me, Milan, she said that mental health to hota hi hai, because panic attacks hai, anxiety attacks hai, cognitive dysfunction hai. Aapko even there is a term called cloud fog, brain fog. Okay, so there is a brain fogging. I mean, you definitely tend to lose what you're saying. You lose yourself. That is also kind of a brain fogging. So these are something. And then yes, it's a challenge. Sometimes what say happens, schools में मिलता है anemia मुक्त भारत का बहुत
Sorry,
show.
Dr. Sudhi, we have to interrupt you. Like, we have only 5 minutes and we
Okay,
are
I'll just quickly fill in because I don't want to leave the fight. I'll just take 2 seconds more.
okay, so that we can go to the next speaker.
Yeah, I'll just take 2 seconds more. So सबसे important है, eat your greens, take vitamin C supplements, which help you increase your absorption of iron. Second and important is that there should be some SMSs regularly going. There should be some weekly health education programs, and they should be directly observed iron therapy. I have been dealing with dots, but I now recommend that it should be directly observed iron therapy as well. So thank you all of you, and I hope I was able to, in a short time, able to make you understand how important this topic is for me and for everyone around here. Thank you so much.
Thank you, Dr. Sudhi, and bringing out lot of clinical aspects of anemia among the young girls and even in the like pregnant and lactating mothers as well. So we love to hear you, but time doesn't allow, and we have a limited time. So even if the participant they want to know more about the clinical aspects and love to hear more from Dr. Sudhi, so they can express their thoughts, express their queries in the chats. So now moving to our next speaker. Next speaker is Rupali Agarwal from North. So she is heading the CSR at North. So Rupali ji, we would like to understand as a CSR head, what kind of programs, considering anemia as one of the major and very pertinent issue in context to like one of the major health determinants of health. So how like you place your programs for the organization when you select them, or the kind of selection you do for funding and identifying the organization?
Yeah, thank you so much, Nirmala ji. And good afternoon to all the respected panelists and all the participants. Thanks to Grameen Foundation for giving me this opportunity to participate in this webinar. It's a very pertinent topic, and Bharti ji very well set the context in the opening remarks, followed by the first session, which talked about the socio-cultural aspect of anemia. So when we talk about any of the disease, so social determinants becomes very, very crucial. So when we see the disparity between the male and female having anemia, so there is a drastic difference, which itself shows that the importance of social determinants. Though there is a physiological difference as well. So women has to menstruate, then they undergo pregnancy phase also. But despite this fact, we can't deny the socio-cultural differences, which is very much evident. And there are regional variations also. So we can see the difference between the rural and urban setup, between educated and uneducated. So a lot of discussion has happened around the social cultural aspects. So I want to highlight 2-3 aspects. So when we talk about anemia, we have to understand, though it is crucial for an individual with respect to their own health, but how it's impacting the family, how it's impacting the community, and how it's impacting the nation at large. So that also need to be think about, like the anemia is contributing to 1.2% of overall GDP. So this is the kind of impact anemia is creating at the GDP level, at the national level. And if we talk about the YLD, which is the public health indicator, so it's the year lost due to disability. So if we talk about globally, then it's around 50.3 million years in 2019. So these many years have been lost because of anemia. So this is the gravity of the problem. And the previous speakers have already mentioned how we are seeing the trend is increasing despite all the efforts being put by the government, put by the CSR, NGO sectors. Everyone is working towards improving the health indicators. Despite this, the problem is increasing. So we all have to come together. We have to do the assessment. And I really want to congratulate Grameen Foundation for bringing out this panel, this webinar, to brainstorm among all of us to find out the actual root cause of the problem and how we can address it. So when I see anemia, then I see that it's across all age groups, right from childhood to adulthood. Everyone is suffering from anemia. So one approach is to work on all the age groups, which government is also doing. A lot of government programs are focused towards addressing anemia among children, also among pregnant women. But somewhere I think the approach is not very comprehensive to reach out to adolescent as well. If we want to break the vicious cycle of anemia, then we will have to have a very focused approach so that we can hit the nail and could get the result effectively. So my preference in my programs, I always feel to work with adolescents. So previous speakers, previous panelists have also emphasized the importance of this particular age group. So this session is basically about physical and mental impact of anemia. So when we see adolescents and the adolescents suffering from anemia, so then this age group becomes further more challenging. Because as we all know, adolescence is the age when the individual undergo a lot of transition, a lot of physiological, psychological changes, reproductive developments are happening. So onset of puberty is one aspect, because of which the female undergo menarche and the menstrual cycle starts. So monthly loss of blood. And on the other side, because of social reasons, the nutritional intake is quite less. And again, if we see the social determinants, the causes are different. In rural setup, we will see completely different reasons behind lack of nutritional intake, whereas in urban setup, we can see completely different reasons, which the first panelist of the session, Ms. Millian, she also highlighted that how body shaming is a reason that is more prevalent in urban setup as compared to the rural. So we have to understand the cultural setup where we are addressing the issue, and accordingly we have to design the interventions. And I was also going through some studies, and interestingly, I found the previous speaker also mentioned that the age of puberty is coming down. And it also puts more emphasis to work with this group, adolescents, because the early onset of puberty means the girl, in early years, the age of menarche was 14 years. Now it has been lowered down to 9 years. So it also creates a lot of challenges and complexities around the age group. And if a girl who is facing early puberty and having anemia simultaneously, so you can understand the challenges, the kind of physiological and mental challenges that the girl might be going through. So this is a very complex problem, and anemia also could make the individual prone to other infections also. because it could lead to poor immunity system, because of which the chances of catching other infections, communicable diseases like tuberculosis, that also becomes very high chances. So these individuals are kind of become prone to other diseases. So, this is also very important to consider. So to address this issue, I think we have to have a holistic approach wherein we have to think about promotive healthcare, preventive healthcare, and also the curative. So when I say these things, so promotive means we have to work on providing health education, because health seeking behavior is quite poor in our society. We already have discussed this aspect. So health is not a priority for us at all, especially for women. So for women, their health comes at the last. Unless we become really sick, not able to wake up and do the household chores, we keep on continuing doing work. This is the kind of culture we have. So in this kind of cultural scenario, it's important to work on health education. And because the anemia is very curable, so we have to understand it's very easy. It's not like a disease like cancer, which is very difficult to treat. It's something which is very preventable. With little efforts, we can prevent the anemia. But I think we have to understand what's the reason. Is the social determinants are so strong because of which we are not able to? Or like the previous speakers mentioned, the limitation of providing the medicines, curative, because the kind of scale we have of anemia across country, so it require intensive approach. So in my experience, I have realized that in Rashtriya, this Anemia Mukt Bharat program also, so government has done the screening. They have identified the children in different categories of anemia, but they don't have the medicine. So curative aspect is missing. So we know the problem, but we are not able to treat it. So that's why I'm saying it's very important to have a holistic approach where we provide the health education, we do the screening of the population, and then we should be able to provide the treatment also. So that there should be early diagnosis, early treatment, so that we could address the problem in an initial stage. So yeah, with this remark, I want to close my, Thank you.
Thank you, Rupali. Thank you for sticking to the time, and thank you for giving the insights. However, I was more keen to understand like kind of programs and interventions in terms of any to deal with anemia. Nor is supporting.
Yeah, Nirmala ji. So yeah,
So,
sure. We are also
yeah, we will later, discuss because
Sure.
already we are running short of time. So
Okay, all right.
Parmeet, do we have time for QA?
Yes. Audience can write their questions in the QA box.
Yes. So, like later, once the I think the discussions are completed, then we take the question answer, or we can take now.
You can take now.
Okay. So now it's open for the participants. If you have any kind of a question, please. No questions?
Dr. Sheila is having one question.
Yeah. So yes, ma'am. Sheila, ma'am, you can have your question.
Ma'am, you may please unmute yourself.
I hear the speakers very clearly mentioning about adolescent girls. I'm very happy to. I've just completed an in-depth study of anemia in India, and I would like to say that the maximum studies that it came across is anemia in adolescent girls in terms of programming and in terms of innovation and experimentation than in any other age group. So that's a good news. And it is a part of the AMB program where we have not put our attention is, of course, in the quality of implementation. We have the only only population group for which we have a guideline is adolescent girls in our AMB. For the others, we have what, but we don't have how. But in adolescent girls, we have how. There are a number of gaps. I'm not saying it's complete, but I just wanted to bring to your attention that adolescent girls is being handled much better. Coming to hearing everybody, I think being a public health nutritionist, I would like to mention that we didn't talk about iron in food, I think, and bioavailability of iron in food. Diet could be nutritious in terms of which it is not, but we are particularly lacking iron in our diet or micronutrients in our diet, which is our biggest problem. Because even if we eat a good diet, which is adequate in protein and calories and carbohydrates and fat, as was mentioned, but at the same time, if we don't consume enough vegetables and fruits and iron-rich food, which is bioavailable, we will go on having anemia in every age group. And for getting bioavailable iron, it's not easy because of the purchasing power. So I'll just cut it short here because I have a chance to speak, so I'll mention it there. But I think IFA tablets is a solution, and we have to promote it more effectively than accepting it that the supply issue is being sorted out by the government extensively now. And I think we need to accept it that there is a supply study has been conducted. There is a lot more focus today. It was a very big problem. It continues to be a problem, but the gap has been reduced, I must admit. I'm not saying the gap has been closed. So next, when I make a presentation, I'll bring to your attention some of the items. Thank you very much.
Thank you. Thank you, Sheila ma'am, just to bringing out this micronutrient aspect in anemia. And you are very rightly said, like even the Poshan Abhiyan that is largely now addressing, apart from adolescent, it is also addressing the pregnant and lactating mothers. And now through the SHGs, lot of organizations, they are coming up with interventions to address the eligible couple and the lactating mothers who are not part of the systems, and they are mainly, lack even the testing. So there are, even Piramal is doing a lot of intervention with the SHGs, where they are, doing like on quarterly basis anemia testing, and so that this could be addressed, and where clinical or non-clinical interventions are required. So I think we have the panel who took a lot of time. So now over to Parneet, and thank you panelists for giving such a wonderful clinical and the programmatic insights on anemia, considering to the adolescent and the younger population.
Thank you all the expert panelists.
And 1 minute. I think Dr. Shruti has raised her hand.
Okay, fine.
Okay, so thank you for that, Krishna. Thank you so much, Dr. Krishna. Just wanted to congratulate Dr. Veer that yes, because indeed the gap is very wide, and it's 59.1%, close to 60%. And having worked on that, I think congratulations to you if you have been doing an in-depth study, and will definitely be. I'm actually waiting to hear you actually. So thank you so much, Dr. Veer. Yeah.
Thank you, ma'am. Thank you all the expert panelists and moderators. Ms. Nirmala Mishra ji, thank you for sharing your profound knowledge. Let's commence our last but not the least, session 3, policies, gaps and challenges to reduce anemia. I extend my cordial welcome to our esteemed moderator, Mr. Saurabh Singh, Senior Project Manager from Grameen Foundation for Social Impact. He has over 12 years of experience in impact consulting, inclusive finance and digital transformation. Our eminent speakers for this session are Dr. Bhavna Sharma, India Head Nutri Science Division from ITC Limited. Being in the field of nutrition and public health since last 2 decades, she has held many positions across R&Ds and corporate functions towards developing and executing the core commercial nutrition product strategies along with policy development. She is recipient of many prestigious awards, namely Excellence in Nutritional Leadership by Ministry of Food Processing, Business Excellence Award for Nutritional Strategy, etc. She is also the member of many national and international nutrition and regulatory groups. Our next speaker is Dr. Sheila Veer, Director, Public Health Nutrition and Development Center. She has over 4 decades of experience in the field of public health and nutrition and was also associated with UNICEF India. Our next speaker is Mr. Siddharth Vagulkar, Deputy Head, UN World Foundation Program. He has more than 12 years of experience in the field of public health nutrition. He was worked across multiple states in the country with government as well as private sector partners and has effectively contributed at the national and state levels on nutritional policies. I will now request our respected moderator to lead the session.
Hello, everyone. Saurabh Singh from Grameen Foundation here. Can you hear me?
Yes.
My voice. Yeah. So, hello, eminent panel member. This is the best part about being a moderator. In the last session, you got a very quick crash course of last 2 sessions. So I'll pick few pretty relevant points. I'll first point out the government of India has made a vision that they want to be a $5 trillion economy by 2025. And then Dr. Nath was pointing out, on the second hand, we had another objective to reduce anemia by 25% by 2025. And then there was a very good, valid, very nice insight given by Rupali ma'am that loss of anemia contribute to a huge amount of loss. So what if we could have tackled anemia like 5 years ago, how much enough money we could have generated from GDP in the term of GDP. So I'm just putting it, quantifying the unquantifiable, that what Dr. Nath was saying, unquantified, underreported, hota hai, chalta hai. Can we put that quantification? Wo chalta hai, how much lost India has suffered because of chalta hai attitude. Wo to aurat hai to thakegi. Wo to har mahine ka issue hai. But that is contributed a lot of things. Female participation has gone down. That has impacted GDP a lot. So, to my panelists, it's really good if you can help me to bring the gap. How you reconcile the fact that we're talking about increasing GDP and the amount of leakage we had in the last 70 years because of very things called anemia, we couldn't fix it. And it's very multidimensional. I was actually, we talked about menarche, the women are, the adolescent, the age where the girls start menstruating is decreasing. It's now 8 or 9 years. It used to be 14, 15. And I have a daughter who is 3.5 years old. So this is something it's very personal, and it's something I really want in the last session, if we could bring together whatever you have discussed so far, and we can come up with at least some good policy points, especially what Dr. Veer was suggesting, that they have done some study. You can just pick some of those points. What do you think should be the policy guideline, where the policy should be heading this to make anemia a central point, and to make anemia, like we see anemia as a very women-focused problem. Can we make it a public health emergency? Because you're losing your money, your workforce it's not going to be competitive in global market. So in the I just want to bring more and more dimension from a public policy perspective. So that's why what government is doing now and what you think they should be doing. So like 2-3 questions, 2 questions for you guys, for all the panel members, and third, whatever you want to pick. So that's how I want to moderate the session. Every panel member has, I know you have much more wisdom to give, but we have to put a hard stop at 5 minutes. So I'll give a buzz at 3.5 minutes, and then you can wrap up. Is that fine?
I thought it was 5 minutes.
Yeah, for 5 minutes, I'll give you a buzz that 70% time is over. Yeah.
3 minutes is very little.
No, 5 minutes. Ma'am, take full 5 minutes. Full 5 minutes. Yeah, okay.
Thank you.
Yeah, start. So we have Parmeet. Can you tell the order who is first? I think Bhavna Sharma. Yeah, Bhavna ma'am. Yeah, you can start.
Yeah, hi. Good afternoon. Thank you so much. And I think I've been listening to such eminent speakers before me, Dr. Nath, Sheila Veer ma'am here, and Dr. Krishna. So I think it's also probably a learning lesson for me, right? I think I'll just come straight to the point, right? I think anemia just from and you talked about, the economic costs and everything like that. And I think, while I probably didn't, hear the whole thing up, but almost, if I'm not wrong, 1.81% of our GDP actually is impacted, of India's GDP eventually, because all the physical and cognitive losses that happens because of anemia, right? That's number one. Second, we have been measuring anemia from what NFHS, when it happened, 1998, 99, and the latest one that happened 2019 to 2021. And the numbers, if I take for two of the most vulnerable age groups, right, which is for pregnant women and adults and young girls, the number has actually gone up. Of course, what has happened also very lately, I'm sure a lot of us is aware that maybe in the NFHS 6, anemia is not going to get measured. It's being dropped, right, for whatever reasons. And it's going to probably get mapped into a different study. And the reason which is given to the public health people is that the way we were measuring it is not the most accurate measure, right? So we are going to drop anemia from the biggest national health surveys that we've been doing, and we're going to have a sample size of 10,000. And it's going to be called a separate diet and biomarker study, and anemia is going to get measured by that, right? And only time and the data when it comes out will tell us that whether it's the right or the wrong move, how is it being done when anemia reporting happens, right? So one of the biggest questions that you started off with to say that, what is one of the biggest gap? I think one of the biggest gap that we're still tackling with it, the latest being, what is still the right measure to measure anemia, right? Because we always start with a number. What gets measured gets monitored, right? So we are still measuring the fact that what is the still right way? So if this is the right way, and the numbers have been not reported to the best way that they have been done in the past many, many years, then probably this is going to be the first time when we'll actually get to know how bad or good the situation is, right? So you can call it gap, and you can also call it an opportunity or a corrective measure. So, however, this is the starting point, because everywhere you go, every single presentation will start with the data to say, itne % pratishat log anemic hain. So we are going back and understanding that number first. And I think I'm fully in supportive of changes which can happen in a good direction. So one of the things that is going to be one of the biggest challenge or the opportunity area for us is to include our own, and we have a lot of experts here, but there are a lot of more experts outside. I think the basic and the most simple thing that we can all do is to come together and to make sure that whatever inputs can be given to that survey, and when the survey comes back, have a open-minded, deliberate discussion to say, what is the comparative, what is the number, and how does it look like? That is literally going to be the number one thing, because that's going to set the bar of anemia in the country going ahead, right? That said and done, the second biggest aspect that comes is, what are the other gaps? See, as the head of, as a nutritionist all my life and now heading CSR, I am been taking this project called Samposhan in many parts of the country, including Karnataka, UP, and other places. And we've been talking to 2.5 lakh adolescent young girls, pregnant women, lactating mothers ourselves. And you will not believe that even today, after so many years of work and the things that have been done, one of the biggest challenges that still lies as the gap are two things. There is still a missing local context to the work that we are still doing. The way you can reach out and approach, and there was a purpose that we did, for example, for our CSR project Samposhan, we did it in few places in North and we did it few places in South, which included some tribal areas as well. The absence of local contextualization of public health messages is probably the single most factor which is causing the gap. The kind of vegetables which are grown in South and the tribal areas as available versus the kind of vegetables and the things which are available in the are drastically different. If you open a book which is giving you the guidelines for anemia, they're all same. Itni green leafy sabjiyan khaiye. Of course, you're supposed to translate it, right? But it's not happening. It's not happening. So one of the biggest things, and I will tell you honestly, when I started this project of Samposhan 2 years back, I thought I will spend all my money in doing high-end stuff. Let's get cool diagnostics in, let's get all these amazing new science approaches. We'll talk about bioavailability and everything like that. But once you actually go down, and I've been to those tribal areas and all those places where they're not even interested in eating sometimes the midday meal or the kind of food which is given to them through the government. No, they are selling the amazing vegetables which is growing in their backyard and selling them for something which is more stapleish and will not give them any kind of a micronutrient, especially iron. Nobody is telling them that, right? So this is the reality that is happening. And the gap, because of poverty, illiteracy, limited awareness, the kind of disparities, unfortunately, we have, that is increasing. And you will not believe, within 6 months, once I got the baseline study, I had to redirect my objectives and my money to come down to the fundamentals, which a lot of people say, हाँ तो इसमें क्या बड़ी बात है यार, ये तो करना ही होता है. But you will not believe, just simple things of contextualizing the awareness, the education, connecting them to their NRCs or the PHCs, talking to those ASHA workers, आंगनवाड़ी workers, incentivizing them कि भैया ठीक है कोई रिपोर्टिंग नहीं होगी, आप बस दे दीजिए, उनको यहाँ ले आइए, हम मिलके कर लेंगे. और उसके लिए ये आपका एक छोटा सा रेसिपी है. ठीक है, आपके पास चने हैं, हम तो चने से काम करेंगे. If you have something else, तो हम उसके साथ काम करेंगे. That made the difference. Nothing else. See, they are not listening to our bhashans. They are not part of this webinar. Okay. They need that one person to bring that change, but to convince that one person is what we need to do. If we are able to do that through our CSR, through academia, knowledge, government, political, whatever it is, I'll not go into that because we all can come from different faiths and beliefs for certain places and that. And second is, of course, implementation strategy, which goes on by different people, because believe it or not, when you enter in any places, and we all have been onto these places, whenever we go there, they said, "Abhi 10 project chal rahe anemia ke, kuch naya batao. Let's talk something else." But the fact is, it's still not getting solved. So while, of course, which also tells you that it is difficult to solve it because it's multifactorial. Otherwise, hum kab ka solve kar chuke hote. So the thing is that it requires that kind of simplicity to do that. My last point, probably I would leave it because we're talking about food, and I think we've heard Dr. Nath talking very beautifully about the whole medical part of it. I wanted to touch base about the food part of it, and the question of bioavailability also came. I did being part of R&D, I actually picked up 5-7 salts, of iron, from bisglycinate to, ferric pyrophosphates and all those things. Generally, the bioavailability will lack anything between 8% to 12%. इससे ज़्यादा किसी की भी नहीं है. You cannot invent a new salt. Whether you use it for pharma, whether you use it for Nutra, whether you use it for any format of it, इससे ज़्यादा salt का bioavailability है ही नहीं, iron का. That is why we had such high RDAs to say कि अगर 30 खाओगे तो शायद 3 मिल जाएगा. That's the math. I'm speaking very crudely, but I'm saying we can't invent that thing. However, what we can do maybe is that identify a format which is more accessible. Like, for example, there is a high-end world of nutraceutical and pharmaceutical and nutraceutical, let me put it like that, which is not accessible to everybody, and not everybody is interested in eating pills all the time. In fact, one of the reason IFA sometimes doesn't work because गोलियां थोड़ी देते रहेंगे. ठीक है, एक बार दे दिया, 1 महीना दे दिया, उसके बाद थोड़ी लड़कियां गोलियां खाती रहेंगी. या हम प्रेग्नेंट हैं, अरे प्रेगनेंसी में पता नहीं कौन सी दवाई खिला दी. We've been doing it, all of us together, but it's not working. So sometimes that doesn't work. Pharma में generally you do it interventions when it's kind of serious, or they come to you when it's already serious, right? So what leaves behind is food. Simple. Food में 2-3 चीजें हैं. There's staple food which you eat every day, right? अब उसमें भी we have the north and south की, यहाँ wheat है, यहाँ rice है, इसमें ये है, उसमें वो है. हम millets खाते हैं, हम तो रोटी खाते हैं. There's a whole world there. And then, of course, there is whole kind of packaging foods, which probably could be a good or not so good carrier of iron in the most best way. I will not go into that. I will just come to one simple thing. In my understanding of the world and fortified cereals, and I'm part of the FSSAI conversations at some level on fortification. In my view, when I went to that, I found salt, and I think it is still coming up, double fortified salt as being one of the most enabling factors. See, salt is something nobody fights on. सबके घर में नमक यूज होता है. गरीब से गरीब, अमीर से अमीर, north, south, east, west, सब salt खाते हैं. Also, the beauty of salt is you can't overeat it per se when you cooking or using it that. Besides any other packaged foods, because that we all know, you can always over index on it, and it can lead to many other issues if you are not able to manage it. However, salt is something that you always put to taste, right? And when you and I'm talking about the one that you use at home or you're cooking at home, the normal salt that ghar pe aata hai. So the FSSAI has already laid down those, the amounts of iron and iodine that needs to be added to salt. Iodization is already there. 70% of the household gets iodine. And through the public health doctors, specialists, community people, we've done our own sensory surveys. And trust me, all the gaps that I heard to say, कि, if you put iron in the iodized salt, वो तो red हो जाता है, उसमें red block आ जाता है. Can you imagine? It actually doesn't happen because once you start putting it in the curry, because nobody's really keeping that curry for 5 days, right? We eat in 1 day, 2 days. We actually have done it with the subjects, and we didn't find any significant difference between the taste, the sensory, the smell, or the look of the curries. And we also actually did a clinical study to see the impact of double fortified salt on serum iron, not only just the hemoglobin prick levels, and we actually saw the iron levels going up in adults and young girls versus when they were just having iodized food. What I'm just trying to say is very simple. While hygiene, health, curative, and everything is there, but as a public health nutritionist, as a CSR head, I only have two things to say. Localization of the context for anemia is the 90% of it, right? It is a message that needs to be given, because I've literally spoken to girls who say, अगर मैं IFA tablet खाऊंगी तो मेरा weight बढ़ जाएगा, मुझे खाना ही नहीं है, you know, and मेरे Instagram के followers will not follow me, and I'm talking about a village where I thought इनके पास mobile ही नहीं होगा. So I had to eat the humble pill. She's not eating the IFA pill. And I'm talking about my daily experiences. So just contextualization, local brand ambassadors, education is 90%. The 10% of the conversation, whether it's in terms of supplement, nutraceutical, pills, food, they all have their role and play. I'm not saying one is better than the other, but staple food, जो आप रोज खाते हैं, बिना सोचे खाते हैं, दाल में नमक है, इसमें थोड़ा डालना है, that gets taken care of. We probably could get a little closer to the solution, maybe. And that's all where I stop. So
I would
thank you.
say that so your confusion is context and science. So that two things we have to, Hannah. So yeah, that's
Yes.
a good takeaway. So now we have Dr. Veer. So please, yes, ma'am.
Okay, thank you, Bhavna, to listen to you. It was interesting. I will first of all thank you, Grameen Foundation, for inviting me and to speak in a subject which is very dear to me. I will speak more at macro level, though Bhavna spoke at micro level. I think at macro level also we have a lot of issues because it was more on policy I was supposed to talk. And a concern issue that I will speak more will be on iron folic acid tablets. Though I totally agree with Bhavna that fortified food as a solution has to be looked in more seriously. But we have Siddharth here who will speak about it, I know. And we have a most successful public health program in our country is universal salt iodization. So we have examples to go ahead with fortified food. We should not shy away from that. But I will focus on iron folic acid. I don't know if Krishna ji, you're putting up my slides. If not, I will just go ahead with the discussion as others have done.
So Tanvi, please share the screen.
Yeah, I wanted to go through the slides just to make my point. Okay. I just wanted to say that anemia is a severe public health problem, and I'll explain why I say severe. And next one, please. Anemia is invisible, but it's common, complex, persistent public health problem. I'll just show you slides to substantiate it. People don't feel anemia, but they understand it's a fertilizer for growth, which is a positive aspect, which has come up in studies. They look at the side effects, we say, but they also look at benefits. We have evidence to that. So I'm not very disappointed. I have hopes. Anemia is a universal severe public health problem. I'll mention why. We keep talking about the lowest socioeconomic group, poverty. But what about us? How many of us have got our hemoglobin tested? I would like to know. Or our girls at home tested for hemoglobin and worked at it. Anemia has inverse effect. We have already talked. In children, we must understand anemia is a big problem in under twos, and it may be due to infection also. Next slide. I'll just go through these slides fast. Prevalence of anemia, category of public health significance. I just want you to see the red portion. The last column, which says 40% prevalence of anemia is a severe public health problem. Now, let's see what we see in our country when we look at the prevalence. Next slide, please. 15 to 19 years, 20 to 29, and it's the same in adolescent, early adolescent, 10 to 14 years also. We have the CNNS data now. And we see that it's a severe public health problem. It's above 40% through and through the life cycle. So I just wanted to look at the cutoff of 40% and accept that this is a severe public health problem in across life cycle. Next one, please, which is more of a concern to me, which we forget. The poorest, we have 63.7%, but even in the richest, we have 51%. So please, let's accept that it's a highest wealth index group also has anemia, which is not due to lack of purchasing good quality food or iron-rich food or buying iron-fortified food. It is lack of awareness and taking anemia for granted, as many have said. Next slide, please. And even as education level, when we see the education level on maternal nutrition, we do see a vast difference. But when it comes to anemia, we see that even when they have 10 to 12 years of education, anemia prevalence is 56% against the cutoff of 40%. Next slide, please. When we look at age-wise for children, I wanted to bring it to your attention. Just like undernutrition, anemia is highest in the under 2 groups. Okay. Next one, please. Now, this is where I come to justify that iron folic acid supplementation will answer over 60% of anemia. Globally, we say that iron deficiency or nutritional anemia is 50% and rest is due to many other causes. But we have evidence in our country that over 60% anemia can be amenable to iron folic acid tablets or intake. We have very good projects undertaken before the Anemia Mukt Bharat program came in, especially in Gujarat, where we saw this whole slide is not coming. But as you can see that mildly anemia dropped substantially with the coverage of 84 to 93% IFA coverage. And this can be done in adolescent girls in school. We have a program, as I mentioned, we have guidelines, but our coverage still remains very low. We have lessons to learn. We forget that there are positive experiences in our country, and when we must look at it in detail. Vadodara District Adolescent School Girls Project by Dr. Kotecha is very well documented, and we need to study it, how it was done. Because I think now we know what, but we don't know how. And for how, we don't have updated guidelines. We say RKSB ko use kar lo, RKSK ko use kar lo. Kaise kare unko use, we don't know. Next point. We have similarly a good project called Umang, upgrading marriage age, nutrition and growth. We know marriage age is another problem. When we are talking about gender issues, I am not focused on that. But I'm just showing that anemia with IFA with 86% coverage could be brought down. But what is the IFA coverage in our country? We are already discussing, is IFA the answer? Not in this forum, but otherwise I've heard experts saying, maybe we are on the wrong track. I don't think so. We are on the right track. We don't know how to improve the coverage possibly. And we are not coming up with very clear guidelines on how people should modify it in their state level. We need to help them with hows. Next one. There is a very good production of WHO anemia prevention guidelines for women in reproductive age, as you can see in that box. An analysis of best program practices. This is the first work I did on anemia. It is very well documented for you all to read. Please do read on hows. And there are good experiences from 10 case studies. And I was reading it this morning also. I don't think anything has changed. Yeah. Next one. Now, when we look at what are we doing, because the anemia in women, pregnant women, at least we are very concerned. Even when we look at this as a highest priority group, any ANC is over 70% in our country. But when we come to women taking IFA tablets for 180 days, we say only 26%. Why are we, the women who are coming for ANC services, not being covered with IFA tablets? It's not a question of supply issue. It's a question of not being serious about counseling them, not serious about convincing them, not seriously telling them, okay, if we can't supply you, buy it from the market, because there are many there who can buy it from the market also. Next one, please. I'll go fast now. Anemia program, we have priority and evidence. Today we have high political support because AMB, everybody talks of anemia Mukt Bharat. When I was working on anemia in 2000, early 2000, nobody talked of anemia. Everybody said, kya degi, kya karegi, kuch nahi kar sakte, chhod do, focus on iodized salt or focus on vitamin A. But I think today everybody is concerned and we have the solution. I won't say we don't have full solution, but at least we can reduce 50%, if not 100%. Let's work on that. Let's also have it's a global priority as mentioned by some of the colleagues here. WHA 2012 SDG to be also 50% reduction in anemia in women in reproductive age. There is no guideline that I saw in AMB which refers to how do we reach these women in reproductive age, because they don't come for antenatal care. These are women who are non-pregnant, non-lactating, or adolescent girls who are not reached through schools. How are we reaching them? Some mention self-help group. Yes, very good. What about MNREGA? What about involving private industry who are working with women employees? Like textile industry, tea gardens, why not reach them? Because in tea garden, I did a study in Assam, 100% adolescent girls were anemic, 100%. Highest priority direct causes, we are now talking about direct causes and at-risk factors. And risk factors are the same as was enumerated by many. But as I see in India, maternal education, wealth, area of residence, it is all reduced in better of situation, but is still a highest severe public health problem in the even in urban areas, even in highest wealth index group, even in mothers who are educated. So I think we have to really look at this problem seriously. It's a universal problem. I think first of all, we have to start accepting it's a universal problem. It's not limited to the poor or the low socioeconomic group. I don't think we talk about it. Another thing that I saw that 60 to 70% of anemia is estimated to be in India is possibly due to iron deficiency, while globally it is 50%. And so we can resolve this, as we can see from Baroda study, IFA tablet. But how much coverage should we have? Minimum, it seems about 80%. Why don't we spell it out in a goal? That's a policy issue. We just say reduce anemia by 3% per annum. But if it is IFA tablet is central to our policy, let's spell out what is the coverage that we are expecting. Gujarat, I said, study. Umang, Jharkhand has done very good work under AMB, but very little we know about it, because I think what I saw was the documentation is very weak post AMB on the processes. We have said, ye kar liya, wo kar liya, sab kuch kar liya, but how did we do it? How do I learn how they did it? I think that needs to be given more focus. And CNNS data, as I mentioned, shows the problem. But even in pregnant women, we have not been able to reach over 60%. Only 4 states have over 60% coverage.
Dr. Veer, I just want to interrupt for a minute. We just crossed the time. Can you just summarize one or two points?
Last slide I will summarize. Can I have the last slide, please?
And then you can share the
I can even leave it now. I have no problem. Goal I have mentioned, revisit program design, formulate issue operational guidelines. I think we need that. Create mass awareness. I think this is where we need to create and reach the high wealth index goal. We also need to come up with maybe a social marketing strategy for priced IFA for people in the highest socioeconomic group, like we did for contraceptives. Why not? Ensure sustained IFA supply. And first 1,000 days, like when we are working on first 1,000 days for reducing undernutrition, we should build in anemia, not as a parallel program, but integrated in it. And we should invest in documenting processes and implementation research. And IFA, as I said, make it available open market also for people to buy, price maybe through Pradhan Mantri Jan Aushadhi Kendra. I don't know much about it, but I thought that was a scope. And it's about the fortified food. So I close here. I would be happy to answer anything, but I enjoyed talking to you.
Yeah, Mr. Siddharth, I think you are the next. So we'll take the question in the end. And ma'am, will be great if you can share the slide with the team so that we can share with the participants. I think we have already. Yeah, Mr. Siddharth?
Yes, Saurabh. Thanks. I'll come in. And it's not really an easy job being the last person to speak, but really exciting listening to all the speakers and especially Sheila Veer ma'am and Ms. Sharma as well. So I'll come straight to the point and, and firstly, thanks to the Grameen Foundation and Dr. Krishna for inviting us at the World Food Program to be a part of this discussion. So if we talk about, if you look at anemia and what the WHO recommends as the key strategies to address anemia, the WHO recommends dietary diversification, supplementation with vitamins and minerals, and of course, iron and folic acid, food fortification, and other public health measures as one of the, or as a few key strategies to address anemia. And I'll come one by one on each of these. I'll try and not repeat some topics which have already been mentioned by others, But I mean, the first thing that I wanted to acknowledge on this platform is also one thing that yes, there are challenges, there are gaps in the policies, but the fact that in a country like us, I mean, the problem of anemia has been acknowledged. The fact that we have a program which is completely dedicated to anemia, called the Anemia Mukh Bharat. So I think that is something which we must say that the government does acknowledge some of these factors. Anti-anemia medicines are included in the essential medicine list, which was published in 2022. So again, that is something which we must acknowledge that there are measures being taken. Having said that, there are multiple challenges in implementation. There are multiple gaps as well. If we first talk about the way in which anemia is identified, or say the detection measures of anemia, currently under the NFHS, we were till now using the capillary blood as a means of identifying or detecting anemia. But under the dietary and biomarker survey, under the DAP survey, we would use venous blood. And as most of you would know, venous blood is more like the gold standard, considered as the gold standard. Because if you measure capillary blood, it gives you 1 gram. I mean, the hemoglobin that is detected in there, it gives you 1 gram lesser as compared to the venous. So the point that Ms. Sharma mentioned about the overall load of anemia might just reduce if we consider the dietary and biomarker survey. And this was very evident from the NFHS versus the CNNS survey, that in the CNNS survey, you had a slightly lesser total prevalence of anemia. So I think that is something which we should look forward to, the dietary and biomarker survey. In terms of the programs, we have the Anemia Mukh Bharat program. And before that, since 1970s, you have different programs related to anemia. If we talk about the Anemia Mukh Bharat program, you would look at the supply chain. I think there are challenges in the supply chain of iron and folic acid tablets, and especially in terms of, say, hard to reach areas, especially in the northeastern states of India, wherein the price at which you procure your iron and folic acid supplements would be much higher as compared to what you would procure in the central India. Again, warehouse management and inventory, what is how much of iron and folic acid is available in the field. Uh, the most of the policy implementers or the program implementers would not have, like, I think there's a gap in understanding that. So again, there is a bit of challenge over there. If you look at the other point which my other two co-panelists also spoke about, is around awareness. The fact that हमारे पास guidelines है कि green leafy vegetables खाने चाहिए, fruits खाने चाहिए, vegetables खाने चाहिए, पर कितना खाना चाहिए, and how does it translate down to a lay person on the field, कि उसको कितना समझ आता है उस चीज के लिए, वो कितना aware है, how much does he acknowledge anemia as a problem, is something we need to work on that. Awareness and behavior change is something which we need to focus on. The other thing is convergence at the governance levels की बात करो, तो convergence की अगर बात करूं, हमारे पास school level programs भी हैं where we are giving iron and folic acid tablets. We have programs run by the health department, we have programs run by the ICDS. But how many occasions do these three departments talk with each other? There have been improvements, there have been cases where we've seen good models, but again, school में कितने बच्चों को tablet दिया, do they talk with the health department? Again, that is something which we need to work for. Dietary diversification की अगर मैं बात करूं, all of us would acknowledge that to eat a healthy and nutritious diet is desirable, but not definitely affordable for most of the people. So again, uske liye bhi we need to work. I mean, Government of India has a lot of programs. They have the guidelines, like midday meal की बात करें, so we have the guidelines for the kitchen gardens there, कि जहाँ से vegetables and fruits को हम लोग cultivate कर सकते हैं. But again, we need to show operational models through which we can generate evidence around the impact of kitchen gardens and something. Sheila ma'am ने vitamins and minerals की बात करी. We talked about the focus around macronutrients, but micronutrients is something, the discussion around micronutrients is missing. So again, that is something which we need to focus upon. Again, the fact that dietary diversification की बात करते हैं, पर कितने लोग inhibitors of iron absorption को जानते हैं, कितने लोग facilitators of iron absorption को जानते हैं. Again, simple things like खाने के साथ जो चाय पीते हैं, coffee पीते हैं. So those are things which we can improve in our dialogues. Coming to one of the other aspects, which again was stressed upon in Ms. Sharma's and Dr. V's discussion, was about food fortification. food fortification is an area where we at the World Food Program have been working across since many years.
Okay.
And there is specifically on rice fortification that we've done.
So Siddharth, so sorry, I just want to summarize a couple of points here. I think this coming out to, so you said something about communication, convergence. These are the two key points from yours and other panel. I would say context from the first panelist and ma'am, the Ween ma'am, how the acceptance that there is an issue. I think these 4-5 points are good summarization if we have to put it out this conference for the policy intervention. I like the word convergence because that's really so. What we'll do, I think that's the good point for us to summarize. We're just running short of time, so I'll sorry. Please, Krishna ma'am. I think it'll be good if you can we can have the next item. Pramit, yeah. Sorry.
Yeah, so I think we can give 2 more minutes to Siddharth because he is on his way. So yes, Siddharth, we are here.
Thanks, Dr. Krishna. Yeah. So I think I'll just talk in a bit about the food fortification aspect as well. At the World Food Program, we've been working around rice fortification, and in April 2022, you had the Government of India launch a massive program on food fortification. If I talk specifically about fortified rice is available across all the districts and states of India now. And that is because primarily the Department of Food has taken a very big initiative to distribute fortified rice to the Food Corporation of India. If you go to any school, any Anganwadi, any PDS shop, you would notice that there is fortified rice which is available. But there is a tag or a label, specific label, which is displayed on the bags of rice, and these are fortified rice bags. Again, I think what I wanted to also come to the fact that availability of fortified rice has improved with the department taking a very good initiative. But again, the key factor here also remains is that there are many myths and misconceptions around fortified rice. There is a lot of discussions in the media, positive, negative, both around fortified rice as well. At the World Food Program, of course, we do believe that fortified rice is not just the solution. We are looking at multiple pronged solutions for reducing anemia. But yes, the general public also needs to be made aware about fortified rice as to why is it being given to you, or why is it that fortified, what is the benefit that you're going to derive from fortified rice, or how do you simply just basically like normal rice, and how are you going to make it at home. So wo cheeze jo hai, I think that is going to work around through the awareness part of it. And Saurabh, you talked about it. So I think awareness is something which is very important, be it fortified foods, be it dietary diversification, be it the anemia of Bharat. I think awareness is something which emerges as a very key theme. So I would end at there, and I would request Dr. Krishna, I think you can come in now. Thanks a lot for giving me those 2 minutes. Thank you.
Thank you all the seasoned panelists and moderator, Mr. Saurabh Singh, for offering their deep knowledge and expertise on the crucial topic. I would now like to welcome Dr. Krishna, Associate Director Health and Nutrition from Grameen Foundation India, to summarize the session with her profound expertise and convey the vote of thanks to our esteemed panel.
Thanks, Parmit. So I think all the sessions are very informative. Today we discussed a very important topic, tackling anemia.
Krishna, your voice is not coming. Can you?
Not coming? Give me a second. No, it's full.
Now it's coming. Now it's coming.
Okay. Yeah, internet is unstable. Okay. So starting. Yeah, okay. So I think in India, almost 40% of girls and 18% of boys are anemic, and with variation by region and state again. So anemia among adolescents adversely affects growth, that we all discussed, and resistance to infections developed, cognitive development reduces, and work productivity also reduces. Gender and other disparities which we have noticed here, that yes, it's have made marginalized adolescents vulnerable to the economic ramifications of containment measures. Given the risks identified, there is a pressing need to put adolescents at the center of establishing priorities for their health, and agenda for post-pandemic recovery is required. So ignorance, poverty, negligence, lack of access to healthcare facilities, etc. are, I think, a few of the causes that we discussed and that are deteriorating the situation. Government has started multiple adolescent nutrition programs at the central and state levels, namely that RKSK, Sabla, WIPS, AMB, NPAG, all seek to enhance the support and education of adolescents, girls, by providing them with the necessary dietary support and education. But all these programs driving in a campaign mode, but still I think we need to see how we are moving ahead as the statistics improve at a very low pace. We are the first as far as milk production and pulses are concerned, second in fruit production, and third in cereal and egg production. But yet, definitely 4 out of 10 adolescents in this country are underweight, and 6 out of 10 are anemic. So calorific inputs are adequate, but definitely nutrific inputs are inadequate, raising alarm. Though we have tools, a new revolution is required, and nutrition supplementation, local production centers, and maybe many more is still required. I think keeping these facts, this webinar has been conducted as we do not have time, and according to WHO also, we have to reduce 50% of cases of anemia by 2025. Hence, discussing the situation will create and establish momentum, and exactly how conscious are we to deal with the eradicate this anemia. And for that sake only Grameen thought that let's have a webinar and discuss the concern with experts. The webinar looks at a wide array of outcomes impacting adolescents' daily lives, including health, mental, physical, sexual, and reproductive health, vaccine perceptions, and overlap between these topics. Social relationships also, like family and peer pressure, education, socioeconomic disparities, all we had discussed in this webinar. The webinar concludes that social and economic conditions were critical determinants of adolescents' mental health, mood addiction during the pandemic, and that effective intervention is needed to promote their well-being and reduce inequalities. Anemia is now becoming a norm in society, so we need not to create a demand from them only, but to ensure and reduce the gap both between demand and supply. Gender-specific policies are required, giving females priority as the nutrition intake is restricted only at the household level. Mainly 5 common nutrition concerns that I observed. I think the panelists also want to highlight that we have been identified among adolescents these days is the low consumption of fruit and vegetables, whole grains and calcium and low-fat dairy foods, high consumptions of sweetened beverages, and frequent consumption of fast foods. So I think these should be in our behavior change communication. We should tell the adolescent that these should be avoided. Adolescents should focus on vitamin supplements. This is also we have discussed, and iron-rich foods. CSRs are looking into the adolescent age group, but the approach and strategy should be promotive, preventive, and curative healthcare. Inclusivity is to create gender awareness among adolescent girls, empowering them with knowledge about their rights and promoting gender equality. Building an ecosystem for this and bringing it at early stage of life. Adolescence provides an opportunity to correct nutritional deficiencies that may have occurred in early life, catch up on growth, and establish good dietary behaviors. We must support actions to help adolescents make healthy food and beverage choices, promote physical activity, and the prevention and treatment of anemia. In session 3, we address the challenges during the implementation of the government schemes, the inaccurate identification and targeting of beneficiaries, the poor quality and quantity of food grains, and the inadequate infrastructure and capacity of agencies. The government emphasized DABs, to collect data on anemia prevalence, but we need to focus on what is still the right way to measure anemia. And for that, the first point is to give honest feedback to the survey. The strategies to overcome these loopholes, including using information technology, adopting a decentralized procurement system, strengthening the grievance redressal mechanism, and social audits, and diversifying the food basket needs to be looked upon. That is what I feel. Also, we had discussed a holistic approach to intersectoral departments such as education, social policy, water and sanitation is also one of the important determinants in prevalence of anemia that I think we missed somewhere, but that should be addressed. Now, I would like to formally thank our eminent speakers and moderators. So, on behalf of Grameen Foundation India, its entire fraternity, and the organizing committee, I took immense pleasure in proposing a vote of thanks. First of all, my very, very big thanks to the panelist, our moderator and speaker, for such a lively, informative, interesting and interactive panel discussion, and also take out time from their busy schedule to attend the webinar. We'll keep continuing to discuss the topic of various platforms until we make our young girls healthy. Thank you. Thank you very much, panel, for your contributions, patience, your time, and for putting up with our constant email and WhatsApp to ensure that you will be here. Thank you for attending to us. Panelists, my heartfelt thanks to you for all coming together as a collective approach and trying to create an enabling environment. My special thanks to Dr. Smriti Pahwa for the last minute adjustments, who agreed to share her views in the first session. Thank you, Dr. Smriti. I would like to extend my thanks to everyone who helped the team in pulling this webinar together, especially Grameen's CPO, Ms. Bharti Joshi, for supporting us in organizing the webinar. Thanks to all my colleagues who came to rescue us on the various paths while organizing the webinar. My special thanks and acknowledgement to Grameen's communication team for all the technical support at any moment time. We could hold of this without your support, really. We could not hold any of this, in fact. We are really, really grateful. Last but not the least, a big thanks to all my audience, participants who participated so enthusiastically for the entire workshop with constant encouragement, and will take the dialogue forward and for such productive discussion. Thank you, Parmeet, for anchoring the webinar so well. Thanks to all for being with us this evening, and have a wonderful day ahead. Thank you.
Thank you, ma'am. I would request everyone to turn on their cameras, especially moderators and the panelists, for the screenshot. Thank you. Thank you, everyone.
Thank you. Thank you, everyone.
Thank you, Parmeet.
Thank you so much.
Thank you.
Thank you.
Thank
So
you,
much.
Krishna and Ramit and
Yeah,
everyone.
thank you.
Thank you.